Good morning, everyone. It's my pleasure to introduce our speaker for today's Grand Rounds. Dr. Saleh Valez is an assistant professor of neurology. He also serves as associate program director for the Vascular Neurology Fellowship at the University of Oklahoma. He's also the co-director of the Brain Stimulation and Neurorehabilitation Lab at OUHC. Dr. Saleh Valez earned his medical degree from the Colegio Mayor de Nuestra Señora del Rosario in Bogota, Colombia. He later completed a postdoctoral fellowship in neuromodulation with non-invasive electrical brain stimulation and clinical research at the Neuromodulation Center at Harvard University in Boston. He later completed his training in neurology at the University of Chicago, followed by a vascular neurology fellowship at the University of Miami-Jackson Health System. He has an extensive experience in clinical and translational research evaluating the underlying neurovascular effects, TCD, EEG, and FNIRS of non-invasive brain stimulation techniques in different neuropsychiatric disorders, such as stroke, neuropathic pain, and spinal cord injury. Additionally, he has an interest in uncommon etiologies of stroke, including genetic disorders and cerebrovascular complications in patients with mechanical circulatory assist devices and the application of artificial intelligence guided interventions. Without further ado, please join me in welcoming Dr. Saleh Valez, who's going to talk to us about rewiring recovery with brain stimulation and artificial intelligence.
Thank you very much for inviting me and for the nice introduction. I just want to check if my slides are running correctly. Can you see them moving?
Yes.
Yes, perfect. Thank you again. We're going to talk today a little bit about the work that my lab does, which is basically try to rewire using different techniques, which include brain stimulation and artificial intelligence. So I have no financial disclosures, and mainly the disclosure that we have is funding that we receive from several different entities. We will not be discussing any experimental of labeled drugs, but we will be talking about devices that have FDA approval for research purposes. So to start right away, as you might know, stroke is a burden worldwide, and there is about 12.2 million new strokes a year, and that leaves 101 million of people living with a stroke afterwards. And that costs us a lot. There is about 451 billion in cost annually due to stroke, and 1/3 of those stroke survivors end up with moderate to severe disability, which is very problematic. And this is because only about 1 in 4 stroke patients have access to rehabilitation, especially in low and middle income countries. So it's very important the time and the use of rehabilitation services to avoid these major problems, right? But what everybody knows is what we do in an acute phase, right? You have a patient and having an ischemic stroke, and then you either treat IV thrombolytics or, when you can, thrombectomy, right? But the problem is that this is not the reality worldwide. We are privileged here in the United States because we have this available almost everywhere. But when we talk about this almost everywhere, is this the reality? And a big example is what happened in my state, in Oklahoma, right? We think that because we live in the United States, this is widely available, and it's not the case, right? So this is a map that shows what are called healthcare deserts, right? And the reality is that 77% of the rural counties in the United States are considered medical deserts. When you get black in the picture, it means that all of these areas are considered completely healthcare deserts, right? And the more you get 5, 6 is how they divide into services that healthcare facility can provide. So the more blue that we see, the worse. So you can see it's a lot, right? And the little gray areas that we see is where there is total availability of resources. So when we look into this, what we did initially was to map the state of Oklahoma and think how much a patient has to drive in order to get treated acutely. And this is what we found. Whenever someone has to drive 45 minutes or less, then we picture it in blue because they have a facility that is around 45 minutes. But 45 minutes is a very important number. This was deemed by the World Stroke Organization as the least amount of time that a patient needs to get to a hospital between them waking up, finding that they have a new symptom, Because of lack of awareness, most of the patients either go back to sleep or are not able to talk to someone or don't have the means to reach to a hospital. So anything in white is a high risk of never getting acute therapy, right? And this shows what we have done on understanding where are the thrombectomy centers located. And you can see here in this little green is very little and it's all focused. We have a lot of thrombectomy in the same three cities, right? Which difficult patients to reach out and receive acute intervention. And the same goes with TPA. The more scatter you see is the availability of TPA or now TNK in the state, right? But is it the same for rehabilitation? Do we have the same availability for rehabilitation, right? As we say before, 70% of stroke survivors will have some sort of chronic motor deficit despite any acute intervention that they receive, right? And the problem is that the delivery of these services is less available and less accessible in many regions around the world. You can see here this nice map. What is the availability of research centers around the world? And we see very little green, which would be very good, and we see very little blue, which is good. So most of the places are acceptable, poor, or absent, right? So there is a big mismatch in the demand. We saw a lot of stroke and a lot of patients not receiving intervention, and more people living and living more with disability, right? So when we map this, you can see actually here the amount of patients that end up with disability adjusted life years because of a stroke is quite high compared to other disorders. So what a patient can do when they have a motor disability and what are the available interventions to recover, right? So it's what we know in a hospital basis: physical therapy, occupational therapy, speech therapy, and then there is new tools that have been used for several years, like constraint therapy that you see here, like robotic therapy, like whole body weight therapies. The problem that these interventions have is that they are not available everywhere, right? Only 19% of stroke survivors can be discharged to an inpatient rehabilitation center, and this is because insurance issues, no available rehab centers, denials from places or for insurances, right? So many patients are discharged to nursing facilities, uh, or they have already used their days of insurance in a year, so they cannot have more rehabilitation, right? So what happens is that very few amount of patients can participate. And when you discharge also patient out and you give them a script for outpatient therapy, we found out that only 30% end up participating in rehabilitation programs, right? And when you go to any area of the United States and you ask stroke survivors, how much is too much to drive to get a session of physical therapy? The major answer was more than 30 miles. So 30 miles is really not much when we look into the size of our states, especially on this side of the country, right? It's about 25 minutes, 30 minutes drive. And they're already saying that if they have to drive that, they wouldn't go to any rehabilitation. Sometimes because lack of kind of awareness of the importance of research, people think stroke happened, nothing to do. But many times it's also because they are stroke survivors. They don't have the means to drive a car anymore. They are unable. They don't have families that can support them to take them to the therapist. So it's difficult the access to rehabilitation. So what we did here was we mapped the availability of rehabilitation centers in the state of Oklahoma based on the duration of driving, right? You can see here in the dark purple color in these areas, these are places that patients that leave each area, you see this little dot, it means this is a driving distance that we create with this map between 0 to 30 minutes. So anything above outside of these darker purple areas, they already have to drive more than 30 minutes. So these patients around all these other areas are unlikely to go to a rehab center and receive stroke therapy. And you see how bad it is as we get to the panhandle. 3 hours drive to get to the closest rehab center. So it's very little the amount of therapy that these patients will ever get in their life, which leads to permanent disability. So why is so important this that I'm showing you in going to rehab and seeing this, right? So this is very important because this graph here on top is very well known in the world of stroke recovery, and it's the graph of patient recovery profile. Basically show how this varies, right? Based on the level of income of a country, right? Patient is at baseline 100%, then gets a stroke on day one, It's new baseline, very poor, and then it starts recovering spontaneously, right? And as you see, there is a major difference between high-income countries, which is us, with availability of resources, and the dotted blue line in low-income countries, right? So rehabilitation is not the same because of the availability of resources. And even though I'm showing you this beautiful graph, it's not the reality for all the states in United States. And when you see here below, it's actually showing you the access of rehabilitation, how does impact rehab, not just being in high-income countries and low-income countries, right? But the graph is not the same. The patient starts at a poor outcome, and then in high-income countries, they have some availability of rehabilitation, so they do recover a little bit, but you see, they don't continue the therapy, so the rehabilitation is never long-lasting, and it's worse in low-income countries. So we see this graph, and we're gonna see it a few times, right? This is what we dream on a patient that has a stroke, has the stroke and improves on its own. This is even if they sit on their couch, they should rehab on their own, right? So when you look at this and you think, oh, this should be the reality of patients, but the problem is that we don't see this often. This is a study that was done in 2020 where they took 412 stroke survivors with similar stroke etiologies and different baseline at the moment of the strokes, and they wanted to track these recovery lanes. So you would expect to see one lane that is similar to this, and actually what they found out was 412 completely different lanes. So not a single stroke survivor had the same curve of recovery, and that's because of what we were talking, availability to rehabilitation, the amount of rehabilitation that a patient does impacts how they recover. So we're trying to think, how can we do to help? And the best way was to understand better what's happening and what is the global landscape of stroke rehabilitation. So we developed a survey partnering with the World Stroke Organization in 2023. We reviewed this survey with several experts around the world to try to reach out and understand better what are the barriers to access to rehabilitation and telerehabilitation, which was an idea to improve recovery in some areas, like in the state of Oklahoma. So in 2023, December, around that time, we distributed the survey around the world. And we had the survey circulating for about 8 months, 9 months. And we then finally analyzed the answers that we got from the world. So we were able to survey around 62 countries, right? Despite trying several times, reaching out to national organizations, we were not able to get any information regarding rehabilitation in many of the countries that you see in gray. And you see in the places where we know there is more availability of rehabilitation, the same was regarding answers. We got more answers on those countries because there's more availability, so people are kind of more engaged about talking and discussing the problem that they have. So you already can see here the major problem that we have, especially in Africa and some part of Asia. So important thing is that many of the answers were given by physicians, right? So this is interesting because we would think that there will be more physical therapists and occupational therapists and rehab doctors involved in responding this, even though we try to reach out directly to many of the rehab organizations, we got very little answer. It was mainly by MDs. And the setting shows again the same problem. The setting was always urban, so there is very little um, personnel, and there is very little people that engage in suburban and rural areas again. And you see here again, mostly from private or large community hospitals, but very little on rural hospitals about rehabilitation. So the main barriers that we found actually to conventional rehabilitation was the availability was limited, right? And there was lack of trained personnel. You can have a building, but if you don't have a physical therapist or occupational therapist that is trained, PMNR doctors, right? And this was something important. PMNR is a specialty mainly from United States, Canada, and some places in Europe. This doesn't exist much in some other continents, right? But one important factor was the lack of awareness of patients on rehabilitation, that rehabilitation really works. And then we asked them about telerehabilitation, if this was an option. And then the problem was economical mainly. Availability of electronic devices. Not everybody has a smartphone. In some places, especially in Africa, I will see we did an analysis based on income and continent. The internet connectivity was poor in many places. There were not caregivers. Sometimes stroke survivors cannot just get a tablet app or a cell phone app around to do a telerehabilitation session or setting up. That was difficult. And mainly, there is also no protocols on what to do when you do telerehabilitation. So this is one of the analysis that we did based on the continents, and you can see here the difference on where rehabilitation is considered essential, right? It's mainly in the west part of the world, right? And it's not really essential in Africa, South America, right? Also, the availability of guidelines is very, very limited, and it's mainly seen in Europe regions where they have developed and work on guidelines, especially with partnership of the World Stroke Organization and the European Stroke Organization there, right? And how many rehabilitation centers are available is very similar to the awareness. There's lack of awareness because there's not enough rehabilitation centers as well. And here is actually looking at telerehabilitation, and you can see knowledge about telerehabilitation. Mainly, most of the places know that there is that availability, right? Especially after COVID, it changed a lot, and many people started thinking that telehealth was an option, right? But again, there's very little protocols and there's very little sites that offer telerehabilitation everywhere in the world. So this is really a new kind of intervention. And here, this was an analysis that we did by country. And we showed the barriers, and the barriers were very similar. When you group them by income level, then you end up having the same problem that we discussed before: fragmented logistics, lack of internet, lack of personnel in low income countries. But even in high income countries, you see this everywhere because it depends on where you are looking at. We have some states that might have a lot of specialists that are familiarized with telerehabilitation, rehabilitation. We have other areas like here in the state of Oklahoma where we don't have it. So it varies a lot. So how can we overcome these issues that patients do not go to rehabilitation or don't have it available, or also there's no telerehabilitation for the patient, right? And the answer has been looked for many, many years, right? We have worked on different opportunities and techniques to provide rehabilitation, like virtual reality, for example, offline recorded session. You can go now on YouTube and find sessions of rehabilitation. There's video games that have been studied a lot. And then there is the one-on-one telerehabilitation sessions. What's the problem? It requires expensive equipment, right? And sometimes it's not user friendly for a stroke survivor, right? Pre-recorded videos do not give you feedback, right? This exercises are just pre-recorded, so doesn't match a patient, right? And one-on-one telerehabilitation has a big problem, and it's that it's limited to staff. You still need a physical therapist available for one-on-one sessions. And when you do larger sessions, it's something that we ask in the survey. When you have more than two patients in a telerehabilitation, is already not really targeting the proper muscles and the proper things that a patient needs to rehab better. So we needed to find actually an answer that was low cost, right? We don't want something that's very expensive for patients, right? That has some sort of connection, video conference to engage the patient, but also that allows us to measure the performance, right? Because the main problem with one-on-one telerehab is using Zoom or platforms like this one, and is that you cannot measure the performance of a patient. So we need to find something that allows us to measure the performance in an objective manner, not just subjective, seeing how they perform through the video camera. So to answer that question, we thought, what is what most of the people have around the world? And then we found out there's 5.22 billion smartphones in the world, representing 66% of the global population. So we came up with this answer in partnership with the University of Hong Kong and the University of Oklahoma, and we developed Smart Rehab. It's actually an application that we created. It's free of access for any patient. The intent is never to charge. This is something to connect patients with rehabilitation around the world because it was developed by us, by physicians, by PM&R doctors that want to help stroke survivors. So we're going to talk a little bit about what it is. Can be used in a computer, can be used in a tablet, can be used in a cell phone, and it's very interactive. And what we use is artificial intelligence. So I'm going to tell you a little bit about the components of artificial intelligence that we use. We use computer vision, which is a subtype of artificial intelligence that basically teaches a computer to understand that a body that they are recording, like here in this figure, has limbs, has parts, and it moves. So it's just basically teaching a computer to see, like if it was our eyes. So in this moment, you see a patient performing the session of rehabilitation. So it creates these dotted lines and it detects joint movements and is able to measure. So as you can see here in this figure on the side, we now see joints of every patient. And now we can see the limbs, so we can measure them. Once we translate this into data, we can actually see the exact range of motion, velocity, and metrics of a patient performing an exercise. This is an example of that specific exercise that the patient is seeing. And this translates into a lot of data that we can actually measure and monitor. Here you can see the exact range of motion that the patient does at every session and how the movement is performed. So we can actually see very the small changes in performance of a patient that we can actually measure and quantify. So this is basically how it works. A therapist assesses a patient when they are in the hospital, so we can actually see what's the new baseline of the patient post-stroke. Once this happens, then with the patient is added into telerehabilitation app, and we prescribe the sessions, the amount of therapy that a patient has to do, and it creates an activity map with daily sessions that a patient has to follow. And then the patient goes home and enters in the app, and it has a very easy prompts. It has videos, it has actually visual cues and written cues about how to perform every session. It shows them how to do. You see here large icons, very simple, very easy, so they can perform, and it gives them feedback. It tells them this is visual feedback. I don't know, I don't think you can hear it here, but also gives them uh, audio feedback, telling them you're doing good, you're not doing good, and this is all done by the app itself without having a physical therapist on the other side live. Then after that, we get patient actually can see their performance because this give them immediate feedback, tells them, hey, look at your progress through time, each limb, every month, how you doing. It gives them actually score because we realize that when you give them something to look for, increasing levels, getting better, getting more experience, passing with higher grades each of exercise, they do it more often, and they do it better. And then offline, our physical therapist and our team can actually review the performance of the patient. This can be done once a week, every day, as often as you have available a physical therapist and actually can see how the patient is performing, right? And detect that progress and actually correct. One of the important things of the app is that it itself changes the difficulty. So if a patient is performing very good on the middle of the week, it will increase the difficulty of the angle or the strength that they have to do. But also, if we see that the progress is much higher and the app is not increasing enough, we can manually also adjust the therapy difficulty. So after that, then what we do is we see the patient one more time and see the actual progress because this is part of research, right? But this part will be not necessary once we go into actual practice. So this is how the app looks in summary. You see very large icons showing them what they have to do, how many sessions, how many repetitions per session. Every time that the patient is going to do this, they have a video that shows them what exactly they have to do and it explains how each of the exercises are done. We have as we partner with the World Stroke Organization, and we have a team of about 30 stroke physicians around the world. We have actually translated this app to 17 languages already. And it's very easy now for us to just add new languages to add more people that can receive this therapy. And then the patient performs the therapy and then it gives them the feedback. So they feel engaged with the app, and at the end, they give them summary. You see here very large icons. They only can either rehab or see their statistics or see their profile, but their profile is very simple. It just has their information, very basic information. So these are some of the original exercises that we started with because we wanted to start simple. It was 8 exercises mainly for upper limb, but now we have up to 32 different exercises. We have sometimes patients that come to us and say, hey, I would like to train how to do this. Then we talk with our team and we develop and add a new exercise to the sessions. And this is what we also can do. It's so precise that we are now moving to very detailed, it's fine movement. Let me just play this. And we can actually track, I think the video is not really running. We can track fine motor movement of the patient. And this is how we assign different therapies to a patient. We add a therapy, we detect the limb that we have to do, and we increase the number of repetitions. This is in the initial prescription that our physical therapist does. And this is how we see. In orange, we see when a patient is not performing the session. Yellow is when they did partially the session, and green when they did a full session. And here I have the video. This is fine motor movement exercises. So now we can actually quantify these little movements that a patient is doing when they are trying to grab a pen, grab a food, a spoon. We can actually measure it also with the app. And we have now fine motor movement exercises as well. So your question would be how we know this works, how we validated this. Now we are using cell phones to track patient performance, right? So we actually perform a study where we compare this iPhone, I think it was a 2017 iPhone, versus the Kinect device that is the mostly used to do any type of video analysis in research. And we measure the performance. So as you can see here, the Kinect in green and the Smart Rehab in this side in blue, you see how similar are the measuring of the tracks of the patient performance, and the same goes here for range of motion. So it's very, very, very detailed, and it's statistically equal to using a Kinect device, and this is using any type of smartphone. So we know we can measure this, and we can measure well. This is how we see the performance of a patient and a summary of how every patient performs. We give them feedback on perfect, moderate, and firm. And we can actually point anywhere in the graph and see the exact range of motion of the patient. What we're working on right now is to connect this with a device that will tell us heart rate, respiratory rate, the amount of sweat that a patient is having, so we can actually monitor even closer the patient performance when we're doing that. And this is a very important thing that AI adds into this. Sometimes we have a patient that has upper limb weakness and then they will use the other arm to help themselves. So we can actually detect using the AI if they're using trick movements. Every single of the exercises that we add them with trick movements, and this is based on knowledge. We feed this algorithm with so much information about trick movements, about performance that he actually detects. So in this case, patient perform here the movement, but here they bent the elbow. So instead of raising the arm straight, they bent, right? So it detect that they were not performing properly. So we call this trick movements. So we can know when the patients are doing this offline. So we don't have to be there watching them all the time. So what is something very important that we get asked all the time is how about HIPAA and patient privacy? So this is the beauty of using computer vision as the part of AI, and is that actually there is never a video that is recorded from the patient, right? What we record is the range of motion, the movement, this graph that the computer makes, but there is never the face recorded or anything by the program. So this protects HIPAA from the patient actually. So it was very important for us to know, well, we developed this, but what patient thinks about it. So what we did was a survey using the telehealth usability questionnaire, and we took patients and we invited them to the lab, and then we sent some of them home to do it, and we asked them what they think about the app. So you see in the community in red on site when they came to the lab, and this is the combined answers. And we asked them question, the more outer it means the more they like it, right? 7 was the maximum score. So when you ask them, hey, is it simple to use? You see, the people in the community even think it was very simple, easy to learn, pleasant interaction. I like to use the system. It gives very clear feedback, receive feedback comments provided to, like if it was an in-person visit, we can recover from the mistake. The error message are easy to fix and clear. They feel comfortable doing this, that, and they think that this telerehabilitation is an acceptable way of receiving rehab. So you see a lot of agreement, and patients like it a lot. So there are several apps, and there's the reality. There's many apps that are you can go on Google Play and find several apps, but the problem is that many of them are costly, right? The cost that we have here is what it costs us to maintain the app live. We get tons of data, so we have to have a massive server to collect mainly the patient motion and range of information that we get. So the more patient we have, that's what it costs, but it's really not a big burden when you compare how much the other things cost, right? It's very flexible. Patient can do it any time of the day. It measures objectively how they perform, gives you immediate feedback, right? And it tracks adherence to tracking. So we can actually see how a patient is performing on a daily basis by the map that we get of performance. It gives them messages daily. You haven't done your session, so they get reminders all the time. So this is The first study that we developed was a feasibility study that we did worldwide. There are 8 hospitals in 7 countries, and the University of Oklahoma is the only hospital and the main PI for this project, together with the PI in Hong Kong that developed the app with us. So we have all these centers around the world testing the app for the last 2 years. So this is what we started. We created the platform. We got the first IRB approval at the University of Oklahoma in the whole world, and we created the first protocol derived for this intervention. And then after that, we got the other hospitals in around July of 2024 and started patient recruitment everywhere in the world. So this is what we have until I believe the last month or so, November 16 of 2024. We have 91 patients recruited around the world. 70 of them completed the 4-week telerehab program, which include daily rehabilitation sessions. And we only had 4 dropouts around the whole world. One of those was here in Oklahoma on a patient that did not uh, uh, get internet connection where he lived. And even though we provided with a tablet that had internet, there was no good signal, so he couldn't perform the rehabilitation sessions. The most important part that we have is of these 91 patients, we had 0 adverse events. And this is very important for us as patient will be doing this at home alone. This is a little bit patients around the world has approved to show some of these videos. I think they can play how they do. And you can see here that in some countries, they don't even have a rehab in the hospital, so they are using it inside the hospital. Sorry. So this is a little bit of the preliminary, very preliminary data we haven't analyzed because not all the patients have ended this, but we did a small preliminary data to send some abstracts to some of the stroke conferences of the patient that we saw. And some of the interesting things that we see very young people having strokes, especially in United States. Uh, Many of the patients live in urban and suburban areas, and the period of the stroke are mainly acute and subacute, and that's where we want to capture the stroke survivors. And this is very important. We don't care if it's hemorrhagic or ischemic. We want to provide rehabilitation to all. Again, we have surveyed many of these patients. This is preliminary data, again, asking them the same. And you can see here, again, what they think. They like the app, they think it's easy to use, the same things with now stroke survivors during this large study. We also asked therapists around the world what they think of the app. And many of them say easy to use, benefit patients, an opportunity to rehab, they liked it to use. And they were concerned about health risk when we asked them which health risk. Mainly was fall. They were concerned that a patient doing this at home alone, they could fall. So we have very important prompts when a patient is doing this and is going to do a standing exercise on how to hold themselves, use their walkers, or these things to avoid any fall. And we haven't had any from these 91 patients. When we asked per country what the therapists thought, most of them say it was easy, more of them thought that the videos were helpful, the training was important, it was a complement to therapies, and this is very important to us. This is not for us to replace physical and occupational therapies. This is to provide them some help because there is not enough of them. So with this, we can have one therapist for thousands of patients rather than having one-on-one patient that and rehab doctors that is not enough. Then again, the concerns that were mainly was the fall risk, right? And some of them raised patient impersonation. Can we know that the one performing the therapy is a patient? And then that's hard, right? And if a patient is going to bring a family member to do the therapy for them, then it's really little that we can do for those patients when they don't even want to try this. When you provide a rehab option that they can do at home, the inadequate supervision because they are not one-on-one being looked, right? And then the lack of technology awareness for some stroke survivors, especially of advanced age, might difficult how they interact with the app. That's why we try to make it very simple with very large icons and very little clicks to get into a rehab session. The suggestion that they gave us was to add messaging tools. We have now added. We developed the fine motor exercise and some functional exercises what we're working now in the last stages, right? More exercises for supine position and more lower limb exercises. These are some of our preliminary results regarding adherence to motor rehabilitation. This was actually done like 4 months into the program. We had completed 3,174 sessions in total in average. So it shows a degree of adherence that is larger than 60% of most of the places. The main problem that we had was in Malaysia. And this is again preliminary. We'll see now with the 91 patient how much is the adherence to all the session, but we were able to complete many, many sessions on that. And then we test efficacy. We use the Fugl-Meyer motor score. That is a very detailed score to measure motor improvement, and we show statistically significant difference in improvement in the upper extremity of more than 6 points, which is actually very meaningful clinically for patients with a stroke. So it's a big difference. Lower extremities at the time of this analysis was not yet statistically significant, but there was a minor trend towards improvement on the patient's endpoint after receiving the 1 month session. And this is just with 1 month. Imagine what we can do if they receive more months of rehabilitation, right? The challenges that we encountered was the ensuring global coverage, the technical issues that there are resolved with the platform, patients and caregivers acceptability to the app, right? Sometimes when the patient have aphasia or cognitive difficulties, it's harder for them to interact with the app, and lack of technological knowledge and patient compliance is still an issue. And patients were concerned about damaging a device, so sometimes they were more careful because the device were provided by the study. But the question was, is therapy enough? What are the next steps? How can we make this better for patients? And this is where neuromodulation and what my lab has been focusing a lot is neuromodulation. So what is neuromodulation? Basically, it's any process. As a matter of fact, this lecture now is neuromodulation in your brain. It's giving you new information that will reshape the way your brain connects, right? The main tools to do neuromodulation is behavioral interventions, right? Like physical therapy, occupational therapy, cognitive therapy. And there are medications, neuroleptics that we can use to modulate your brain. And then there is brain stimulation, electrical stimulation. So this is what we do at my lab. This is not something new. When you look at the history of non-invasive brain stimulation and the people that work in this field like me, these pictures that we often see, 2000 before Christ, electric eels being used to stimulate the brain of patients at that time. And you see these graphs all over the pergaments in Egypt that shows that they use some of these devices to provide some sort of current around people. Use of electric eels to provide some electrical currents. And this was the first electrical stimulator developed in the past. They used some copper, and then it was placed in one of these jars and generated current by movement. So when you are in this field, you get kind of like obsessed with these figures and you see them all the time. And then you see is this real from where they come, right? So in 2024, I was invited to give a lecture at the World Stroke Congress about the work that I was doing. And then this was done in Dubai, actually, in Abu Dhabi. So after this, a university in Egypt invited me to give another lecture. So I say, well, when in Egypt, then you have to go and look for this. So I found it. It was very nice. Nice for me, maybe. But you can see here, it was not nice for my son that had to walk over 5 hours to reach and take this picture with my wife, that actually co-directs this lab with me. She's a PhD and neuroscientist, and he does brain stimulation for the last 12 years as well. So these are the main techniques of brain stimulation, TMS. You might have heard more often because it has FDA approval for treatment of major depression and migraine. And then transcranial direct current stimulation that recently in the past month actually got FDA approval for home-based treatment of depression with a specific device from a company. But they use very little small currents. Transcranial direct current stimulation use a tiny little current, direct current applied with two sponges over your scalp, so they are non-invasive, and that generates a current between the two electrodes that act and that helps target some of the pathways in the brain. And TMS uses a magnetic field to generate an electrical current that actually activates pathways in the brain. One activates, the other one makes easier to activate pathways. So we're going to focus on TDCS because this is the intervention that we're using for stroke rehabilitation. We use mild electrical currents that travel through your scalp and penetrate and deliver these changes in action potential threshold. So we make some pathways to be easier to be activated. We do not activate them, we just prime them. And we prime them and then we combine them with something. So in this case, rehabilitation, because we want those pathways that are easier to activate, make those neurons to connect easier, to talk to each other easier. And this comes from the principle of neuroplasticity, that is, neurons that fire together, wire together. So we want this group of neurons that are affected but that survive, right, on that area surrounding a stroke to wire together while they're firing together. So when we make the threshold lower to depolarize, then they connect easier. He has very few adverse events. This is not new. It has been studied for a long time. I show you the pictures of many, many years ago, but there's studies of over 40 years on safety. The main side effects are mind tingling and itching sensation, and maybe some mild headache because the elastic bands sometimes are too tight for the session. Right, it's a portable device. It's very cost effective. One device can treat thousands of patients. And the most important is that it can be used for many disorders because you have anatomical and functional targets based on how you place the electrodes. It's one of the largest fields in research. There is over 750 studies around the world using TDCAs and more than 800 publications a year using TDCAs. Does it work in a stroke? This was meta-analysis, systematic review meta-analysis from our group, and then it shows basically that the level of evidence is 1 and 2A when you use brain stimulation and you combine it with something else. And what does something else you see here is mainly therapy, therapy, therapy. We know therapy works. So when you prime those networks, it's going to work even better. So what we study in our lab mainly is those effects, right? How the electrical current that we create and how that change connections in the brain, right? So we apply the stimulation and we measure how these electrical fields connect with each other. But we also measure the responses that occur in the blood vessels because stroke is a problem of blood supply. When you apply electrical stimulation, it was established that the heat, the current that produces it, you also changes how vessels respond. So we actually study using ultrasound, TCD, and FNIRS how neurovascular coupling, that is this process of demand of nutrients and the changes that occur time to time in the brain tissue as a response to an stimulus or as thinking and activity, how the vessels change and interact. So we actually study the connection between electrical pathways and vascular pathways. So remember the graph that I showed you initially about how stroke recovery occurs, right? What we want to do with brain stimulation is to shape this graph and improve rehabilitation in patients. So we want to decrease motor disability, enhance motor memory and cognition, enhance independence of patients, decrease days of loss of productivity, and improve functional status of patients. And also this works for cognition. A lot of the research that we do is cognition. So we want to halt the progression to vascular dementia. So I talk a lot about telerehabilitation, and then I come and tell you now you have to bring these people to the lab and provide them electrical stimulation on a daily basis, put this device in their head. So how do we take electrical stimulation to the patient home? So this is what we've been working for the last year and it's home-based brain stimulation. This is what we provide to our patients. It's a small briefcase. They get a laptop in case they don't have, so we can interact in Zoom sessions with them. We provide them a tablet so they do the telerehab, and we provide the TDCS mini stimulator. So it's the same device, it's just remotely used. It uses little batteries and use electrodes and a cap that is adjusted to the patient head, and they just put the cap, connect in the Zoom link, and we control the stimulation from the lab. So this is how the home-based stimulation works. Patient has these pre-measured caps to their head. They can only place the electrode in the area that we want for the study, and they connect with this secure HIPAA app called Electra app, where we control the session that they have because we have had patients that feel so much change that they wanted to do more sessions. So we provide them passcodes for each session so they cannot do it more than once a day. This is our large trial that we're doing. We randomize patients that have a stroke into standard of care, go to rehab, do your conventional physical therapy, to our intervention group that is a smart rehab plus home-based TDCS. The patient receives 4 weeks of intervention, home-based, and tele-rehab. It's all done at home. The assessments are done remotely. we have new tools that we use to measure performance from the patient at home uh, to see if this works more than a standard of care. Then we have sub-studies within where we ask the patients to come little bit, a few visits to the lab just to see how the vascular and neurovascular changes occur. What I was telling you on neurovascular coupling. So this is one of our stroke survivors. What we use is FNIRS. So FNIRS uses infrared light to measure sort of the ball signal, changes in oxygenation patterns in the brain, response to a task. In this case, is the NBAC task, where patients are asked to recall a letter that they have shown before. And this is important because we have seen that the more you impair neurovascular coupling, this response of the brain to activities to move nutrients, oxygen to an area, is correlated with worse outcomes, with worse performance in the MRS. You can see here, worse neurovascular coupling, worse cerebral blood flow, worse outcomes long term. So this is some of the data that we have. This is healthy patients, and then you ask them to do the NBAC task. So then they can pull all the blood in red to an area of the brain that is performing the task, right? When we have ischemic stroke patients with post-stroke cognitive impairment, we see that actually we don't have this pool of blood and nutrients and oxygen to the area is actually lower. So this is again preliminary data that we have done from this ongoing trial, where we have about 19 healthy subjects and 6 stroke survivors that completed the whole intervention of this task, and how the groups look, right? When we use the in-back task, it has different levels of difficulty. So the one back task is asking them to recall the prior letter, right? So you see, controls and stroke survivors do not have any difference. There's no activation. It's very, very, very simple task. We use this as a control. We know patients can do it, can recall. It's very simple. As soon as you do the two back task, meaning they have to recall the word the letter 2 steps before, then you see the controls how much oxygenated hemoglobin bring to the frontal areas of the brain and how stroke survivors lack this response, right? And this is independent of the type of a stroke. It can be a small lacunar, a large hemispheric stroke. There is lack of neurovascular coupling. This is what we call neurovascular decoupling, which is correlated with worse outcomes. So right now we combine this with the intervention. In some cases, this is another sub-study that we have, and this is not home-based. We bring patients to the lab, we connect them with TDCs, and we do simultaneous TCD to see the exact changes in blood flow in the brain. And you can see here how the stimulation type can reorganize how that blood flow occurs in the brain tissue. You see how it's irregular in some cases, and with the stimulation in the left side, it becomes organized and more constant. So we're trying to fix this decoupling problem that happens in the brain. This is what we see when we picture the FNIRS changes when we are stimulating a patient brain. We are showing that we are enhancing the amount of blood flow that comes to that area of the brain, which is also one of the premises that we have. We want to do this in the acute phase to prevent this secondary injury that happens with these small vessels get affected and decouple neurovascularly. So this was from patients, how we activate those areas. This is live when they are receiving the stimulation and with an FNIRS cap on. So the future work where we're working now is now a large multi-center clinical trial is going to start soon. Randomized patients to telerehabilitation versus the standard of care worldwide. Enhancing, it's always more things that we can do to enhance and improve the app. Apply this platform to other conditions. Every time we discuss this, we get interest on Parkinson's, spinal cord injury, cerebral palsy, and that's our main goal, is to enhance this and be able to provide it to patients that need rehabilitation, even if it's from knee osteoarthritis. Combine it more with other interventions like electrical stimulation, do larger trials for this. So to conclude, mainly stroke rehabilitation services are very little available around the world, and as low as 22% in low middle income countries, right? The main barriers are the availability of rehab facilities. We don't have enough in the world, and the lack of trained personnel, and the patient lack of awareness. Regarding telerehabilitation, then the issue become lack of electronic and hardware devices, internet connectivity, suitable caregiver setup of the devices, and the lack of clear protocols. We're working now on developing protocols in partnership with the WSO and the new created telerehab committee. Automated telerehabilitation technologies are promising, and we know that it's feasible after we have run this trial. However, still depends on stroke severity, right? IT literacy, right? And the availability of the appropriate devices. Larger studies are needed, again, to see how this works around the world. And again, remember, I show you this map of the lack of rehabilitation in the state of Oklahoma and the concern that we have to get patient rehab. So I always like to show how much we have reached in the state of Oklahoma. This is where the lab is, the Brain Stimulation Lab and Neurorehabilitation Center and the University of Oklahoma. And these are the amount, this is not the amount of patients, this is the amount of areas and suburban neighborhoods that we have reached out at least one patient. Sometimes we have dozens of patients in this area, but we have reached very far away in the state of Oklahoma with our remote interventions. And again, nothing of this would be possible without the partnerships and the support that we get with many of the physicians. This is some of the team that we have around the world for this large feasibility trial. These are the teams around the world providing the rehabilitation. So without any of them, we couldn't have any of this work. And the lab, the members of the lab, this is not my work. I'm just the lucky one that comes here and presents and get all the praise. But without all the postdoc, the collaborators that we have in the lab, this wouldn't be possible. And that's it. We can open for some questions. Thank you again.
Thank you for that. For everyone, the CME code is on this slide, so please do text the code for credit. Thank you so much for this. This was very interesting, and I think it's going to change things significantly. For anyone, please post your questions in the chat. There's actually a question that I had as well, which is, for the smart rehab, how would billing or reimbursement work in the US?
Yeah, that's a great question. It's something that we are working a lot, especially in the state, right? But it's very similar to telehealth and telemedicine, right? I know in the past couple of months we had issues with telehealth and telemedicine to be reimbursed because the bill that passed this, I think, expired. But the idea is to use the same. It will be as a telemedicine session. And we are working closely with the government and the state of Oklahoma to try to move policy in the Senate, in the Congress, about the importance of reaching out patients. So the idea is it will require a larger bill to be passed to approve this as a telehealth mechanism. But once you see the decrease in cost that you generate when you provide this application to patient, there's a lot of interest from the government on passing this, but it will be as a telehealth.
Yeah, that makes sense because I guess it just for these patients who are not able to move, otherwise they would need a home health person to come in, and that would require more resources. So that makes sense. Okay. There's another question that says, what is the cost of this instrument?
So it's free. We have run it for the last 4 years based on grants from several grants that are local from the World Stroke Organization, but also several local grants in China and Hong Kong, mainly to keep the app and the team, right? We have a group of IT people that keeps the app running. So that's the main cost that we have is keeping the IT people and the platform itself, keeping the information and data is not so expensive. But the whole point is that this is free. We're not intending to charge this. So there's no cost for patients to use the app in the future, which brings a little bit of a problem. Who is getting reimbursed at the end for this, right? It's the physical therapist probably that will be overseeing these patients with the, I don't know, the stroke team that is in charge of this telerehab. At the end, you always need a team to oversee what the app is doing. So I think that's what it will get reimbursed at some point. But it will be very easy because the goal of this was to provide rehab to low income countries, middle income countries that do not have access to any of this.
Sense. Okay. There's another question. What TDCS protocol parameters are you using? Target location, intensity, session duration, number of sessions, and how do you tailor them based on stroke characteristics, especially lesion location?
Yeah, that's a great question. And I think that exact question is the reason why we don't have a FDA approval of TDCS for stroke rehab is because we don't get into an agreement of which protocol to use. And so many things that you listed are what we call the dose. So currently for this trial, what we're using is bilateral M1 montage. So for people that are not familiarized this, but an EEG is the same. We use the kind of like the EEG measurements, bilateral M1 area, the primary motor cortex. Bilateral, that's where we place the electrodes. And we are using the anode in the affected size. So we switch the anode to left or right based on where the stroke is. The milliamps that we use is 2 milliamps. The session lasts 20 minutes, and we use it Monday to Friday for a period of 1 month. So they get 20 sessions of TDCS. I think I answered all of the questions. But again,
Yeah.
when you talk to another group that does brain stimulation in Harvard or in California, they might be using M1 and supraorbital. We have gathered this systematic review that the senior author is Professor Fregni. He has there all the montage and the efficacy. So we found out that bilateral M1 using the anode in the affected side is the one that helps the most, regardless of having a small lacuna in the internal capsula or having a large MCA stroke. It helps with motor rehabilitation. Different it is when we target cognition, then we target the DLPFC as the area of stimulation.
Thank you. Then someone's asking if there's opportunity for collaboration at their institute.
Yes, there is always opportunity of collaboration. We are always expanding, and as we look to move for this next step of a multi-center trial where we are looking to get FDA approval for the Smart Rehab app, we will be looking for more centers in United States. We already have a center in in Boston, in Harvard, with one of our partners, right? But the beauty of this is that in the past we would always need collaborators that knew TDCS and how to do brain stimulation, but we no longer need. We do all the intervention is run and directed from here, from Oklahoma. We ship the devices out of state. So yes, I think in my next slide here I have my contact email. Yes. So you can just send me an email, and Alexandra has my contact too. You can reach out to me, send me an email, and we can discuss collaboration. But yes, definitely we are expanding. So that's one of the next steps. So we're welcoming all collaboration always.
The person who was asking is saying that they are located in India.
Yeah, we have already a center doing telerehab in India. It's one of our partners, and we have a lot of collaborators there and also mentors from the World Stroke Organization. So they can always reach out. The logistics of brain stimulation there, it's just gonna take a little bit more time because we will shift devices around the world, but that's the next step too.
Great. Thank you. And I guess for me, I kind of have the same concern that some of the therapists had in terms of motivation and just for them it was more versus patient impersonation, but also just the not having a person there to kind of push you sometimes makes the person less motivated, I feel. But again, that's probably the person who may not show up for their session. So I think it's kind of similar from that standpoint. Right?
Yeah. It's true.
Great.
When we talk to patients and we ask them what was the barrier, they always say they did not have a rehab near. Then when you put the rehab at their home, when they don't connect, when they don't do it, then it just gets harder because then it means there's very little effort they want to put. We try to put as a game, we give them points, we give them experience levels, we do all of that to keep them engaged. But also we can watch how they perform. So as part of the study, we message them, we call them, we say, hey, you haven't done a single session this week. What's going on? Is there a problem that is from IT standpoint, or you just don't have time? And sometimes lives happen, right? These stroke survivors also have works, have things, have kids, have stuff. So that's a bigger problem, I think.
Yes. I think I echo everyone's comments in the chat as well. That thank you so much for this. This was really excellent, and I think everyone learned a lot from it. Thank you so much for your time. and for
Thank
this
you for
great
inviting
talk.
me.
Great. Have a great rest of your day.
Bye bye. Thank you.